Hello everyone and welcome to the channel. Today we're going to be doing another series where we're going to be breaking down various EKGs, which will hopefully help people practice who have some difficulty with them. I understand that the squiggles can be quite confusing. We'll walk through the EKG interpretation step by step, focusing on identifying the rhythm and understanding the 12 lead. So before we get into lead 2 interpretation, I must say that everyone has their own flow and their own style. I have cherry picked mine and this works best for me. If you have your own way that makes sense for you, then absolutely use that. The important thing is that you use the same process each time and you're consistent. But if you like my process, feel free to steal it. So whenever I look at an EKG, I first try to figure out the rhythm and I ask some simple questions. Is the rhythm regular or irregular? Is the QRS wide or narrow? Is the rhythm fast or slow? Next, is there P waves for every QRS? And if there are there too many P waves? For a typical rhythm, such as a normal sinus rhythm, you should have one P wave preceding every QRS complex. For 12 lead interpretation, I like to think of it as a lead 2 interpretation, which includes the widths, such as sinus tachycardia with a right bundle branch block and multifocal PVC. So first off, we have to determine our exact rate. From there, we get our axis. Then we do our intervals / waveforms, which include our PR interval, if there's any atrial enlargement, Q wave morphologies, QRS width, QT interval, T wave morphologies, bundle branch blocks, semi blocks, all that kind of stuff. We next look for hypertrophy, such as left ventricular hypertrophy, such as LVH, or right ventricular hypertrophy, or RVH. LVH can be determined by a bunch of different equations, which we honestly won't get into on this video, but one of the more popular ones that I know of is the Sokolov-Lyon criteria, and you just gotta do a little bit of math. So good news, we have calculators on our phones. Next, look for extra beats, such as premature beats from the atria or the ventricles. These include your PACs, PJCs, and PVCs. Next, we look for infarction. One of the most critical steps in EKG interpretation is to determine whether the rhythm is regular or irregular. So this EKG is mostly regular, but there are some irregular spots noted in AVF, where there's some extended pauses after some weird beats. These weird beats are PVCs, so the underlying rhythm is fairly regular. It's not bouncing all over the place like you would expect with something like atrial fibrillation, wandering atrial pacemaker, or multifocal atrial tachycardia. Next, we're going to look at the QRS. Is the QRS wide or is it narrow? I'm looking at the QRS in V1 and it doesn't look wide, so it's going to be a narrow QRS. Next, we determine if the rate is fast or slow. Since this is a mostly regular rhythm, you can do the 300 rule. This is just a down and dirty way of figuring out your rate and can quickly let you know if the rhythm is way too fast or way too slow. To do this, you need to memorize a few numbers. In this example, we're not going to go through all the numbers. First off, you need to find your QRS and find one that's on a large big box line. Next, you find your next QRS complex. If it occurs one big box away, the rate will be 300. If it is two big boxes away, the rate will be 150 beats per minute. If it is three big boxes away, the heart rate will be 100 beats per minute. In this example, the next QRS complex is a little before the 100 beats per minute marker, so let's guesstimate the rate to be around 105, 110, which is over 100 beats per minute, so it is going to be fast. Next, we look for our P waves or atrial activity. Here we can see atrial activity before the QRS in V3, so it shows PQRS, PQRS, PQRS. But V1 is super interesting. We can see multiple quote unquote P waves, and there are multiple ones per QRS. I noticed that these occur about one big box away from each other, and if they're occurring one big box away from each other, we know the atrial rate is going to be 300. The only thing that can do that is going to be atrial flutter. Now let's do our 12 lead EKG interpretation. This once again gives us our widths, so it's going to be atrial flutter with X. So first, let's determine our rate. We did that in the last phase, so we know that it's going to be about 105 beats per minute. Next, we determine our axis. To be honest, axis isn't like super important in most circumstances, but if you really want to nerd out and know the axis, here's some ways to kind of remember. Lead 1 is up, 2 is not really positive or negative, but there are some complexes that are negative, but for simplicity's sake, we will say it is neither positive or negative. Next, we will see lead 3 has a negative QRS complex. I personally use AVF to determine axis, but AVF has a bunch of extra beats in it, so I can't use it in this instance. So this is going to be a left axis deviation. A little tip here is going to be the thumb method. I will make a whole nother video on that in the future. Next, we get into our intervals and waveforms. This includes bundle branch blocks or any other issues, such as our intervals. There's no bundles noted because our QRS is going to be narrow. Can't really measure a PR interval due to the presence of flutterwaves, and eyeballing the QT, it looks pretty normal to me and is not super elongated. We're really worried if the QTC or corrected QT interval is going to be over 500 milliseconds. There's an increased risk of an R on T phenomenon, which sends the patient into SODS. Next, we're going to look for hypertrophy. I don't see any hypertrophy here. Hypertrophy such as LVH was going to be more common. You're going to see high voltage stuff. You can also do the Sokolov-Lyon criteria. It's not here. Next, is there any extra beats? We can see an AVF, AVL, AVR. There are PVCs. I can tell they're PVCs or premature ventricular contractions or complexes. And I know this is because they have a wide QRS. Next, we look for infarction. You look at the ST segment to see if it is baseline or isoelectric across all your leads. You can see that there is no ST depression or elevation, which would signify myocardial injury. So in summary, this EKG reveals atrial flutter with a left axis deviation and multiple PVCs. Atrial flutter can be challenging to diagnose, especially when it presents with variable conduction and hidden flutter waves. So here we're going to talk about the best leads to determining our atrial activity. So when we look for atrial activity, we always seem to look at lead 2, but actually our money lead or best lead to look for atrial activity is going to be in V1. So start there, then move to lead 2. If you still don't see any P-waves, look at the rest of the leads. The reason why V1 is going to be the most important one for atrial activities is because it's a septal lead on the right side, so it's going to be basically over your right atrium, which is where all your atrial activity comes from. So to recap, always start by assessing your rhythm, rate, and QRS width when approaching an EKG. Also, look carefully for hidden flutterwaves, especially in V1. Remember that atrial flutter is a re-entrant circuit and has an atrial rate between 200 to 400 beats per minute, with an average being about 300 beats per minute or one big box on our EKG. Atrial flutter is one of the most misdiagnosed rhythms out there, and sometimes you need an EP study to actually diagnose it. You can have a typical sawtooth pattern, but you can also have your hidden flutter waves, such as this example right here. So if you see atrial activity at a rate of 300, always think of atrial flutter. One last tidbit is that atrial flutter can actually be irregular or regular, so be careful when reading the doc in the box, as it might call atrial flutter actually AFib. So thank you so much for watching. If you found this breakdown helpful, please like, share, and leave a comment below with your thoughts or questions. Don't forget to subscribe for more EKG interpretations and clinical tips. I will see you guys in the next video.